We're getting into a conversation this hour, and we're going to be looking at a health issue. Joining us for this conversation is Professor David Gathara, who is with Kemri Welcome, and he joins us in the Situation Room this morning. Prof, good morning.
Good morning.
Karibu
How are you today?
Very well, thank you. How are you?
All right.
We're looking into shaping quality care in newborn units. And as we do in the Situation Room, welcome to the hot seat. We will welcome you with a proverb. Dennis will tell you where that's from, and we'd love to get your interpretation of it.
Yeah, so our proverb today comes from Seychelles, a small island country in the continent, but rich in tourism. They fish a lot of tunas, and tourism is one of the economic drivers there. But let's go straight to our proverb today. Don't overdo things. Everyone breaks eventually. Don't overdo things. Everyone breaks eventually. How would you interpret that?
I would say that everyone needs a break. Everyone needs, you need moderation in whatever you do. Otherwise, if you don't allow space to reflect, to re-energize, then, something takes a toll on you, and you'll have to, the body will make you take a break by force.
Yeah, that's well said, well put.
Indeed.
Yeah.
Sasante. Definitely, the title precedes you, indeed. All right, so we're looking into an issue today around care for newborn children, babies. And I believe that there are terms for that. I'm sure we'll get into that today. But even as we do, why is that important, Prof?
I think first and foremost, we need to recognize that, we need people to take after us. There is a future generation that we need to raise, and it starts from the newborn stage. So if we don't provide the best care for these babies at this stage, then it means we are compromising our human capital. But more importantly is every pregnancy, every family looks forward to a healthy newborn baby. So it's their right that we deliver that. So as a country, then it's an issue of importance, not only from a healthcare perspective, but also from an economic perspective. I
mean, you look at the neonates in the country, or pretty much across the world, and it's a big deal. It's important for this demographic to be taken care of. And if we want to then look at perhaps improving the same, we must first describe the situation we find ourselves in. You find that in this country, especially far-flung areas, it's difficult to access these facilities. So just from where you sit, where are we? How good or how bad is it before we now get into diagnosing this problem and then finding a solution? Just how bad or how good is it?
I think broadly speaking, Kenya has made a lot of strides in healthcare. And I think one of the greatest achievements that we've had is women are now delivering in hospitals. So we have access to care, and which is a good thing. But I think the challenge now is the system is failing, the population, and in this case, mothers and babies, in providing quality care. And to paint a picture of what the situation looks like, in most of our county hospitals where we've done a lot of research in the past, is you find, very high workload. So you find very many babies in a very small space. So ideally, you should have one baby in one cot. In some hospitals, you find 2-3 babies who are not related at all. In some places, you find that they are, up to 30-40 babies, one nurse, 2 nurses. So then it begs the question of how much can you deliver in terms of care from a healthcare provider perspective. And while nurses do a lot of the work, they actually do depend on the support of other healthcare providers. So you need a doctor, you need a pediatrician in that environment. And in some of these hospitals, then because there is only one of them, they can't be there 24/7. So there are instances where they have to make decisions on their own. And if they don't have that support, then it really takes a toll on them. So based on the work that we've done, we've been able to uncover that, just because there was a nurse on duty doesn't mean care was delivered. It means if I had, 20, 25 babies as a nurse, I will prioritize something, and some things will fall through the cracks. And our previous work has illustrated that only about 30 to 40% of the care that a baby needs is what's provided. In the recent work that we've done, we've seen that about 30%, a third of the care is provided by nurses, a third of care is provided by mothers and other people in that unit, and a third of that care is not delivered at all. So the implications for that, it's not as just because there's a wall and a bed and, capacity to provide care. It doesn't mean the care gets delivered because, and I love giving this example that if you had two very sick babies and both of them needed resuscitation, meaning they need, they are crashing and you need to bring them back to life, you can only bring back one of those babies. And if it's just one of you, then it makes a very hard decision. Which one do you choose? And somewhat, unfortunately, one of them, so it's those tough decisions that our health workers have to deal with, specifically nurses, because they are in those units 24/7. It's the circumstances that we have to live with, and the implications for that means that if you don't get all the treatment you need in a day, it means you take longer in that unit. It means antibiotics that were supposed to be for 7 days might stretch to 9 days. It means that the mom stays there for longer. And I think the one thing that we never reflect on is, what does it mean for this mom? She came to the hospital, she's stuck in hospital, she has a family back home. What does that mean? Who's taking care of her other babies? The issues about the relationship with the husband. And in some instances, it's gradually changing, but for a very long time, husbands were not allowed to newborn units. You have a baby, but you've never seen them for a month. There are some practical issues that we need to reflect and be honest and have honest conversations on how to support this environment. And I think maybe to wrap it up is to just flag that when a nurse has 25 babies, they actually have 50 patients because the mother is also unwell. So you have to deal with the sick baby who needs, the fluids, the medication, the feeding. But this mom is also not at peace because she's not sure. She will have a lot of questions about the interventions you are making, and you still have to reassure her. If you don't support her, then you don't get the milk to give to the baby. If you don't support her, then she might not provide care the way it's supposed to be. So you have to train her on how to do certain things because mothers are also part of the process. So from that perspective, I would say we often forget how much care means in a newborn unit. It means that you have a sick baby, but also a mom that you have to support, and that is almost like a double workload that people never see when providing care in this unit.
Prof, there's something we always notice when you go to some of these hospitals, for example, and over the weekend I had a conversation with, I will not mention her name, but she works in a hospital as a general practitioner. And she told me of a situation where, as an intern going in, she would spend 40 hours, 70 hours, and she was just explaining the situation as it is on the ground. And then we ended up having a conversation about how then do you improvise? What do you do? And it was very interesting. My question is, because if right now in this studio, if this mic decides to drop, before we call the technician, we'll have to figure out how to fix this. We'll have to get a band or something. I'll have to get a hairband or a settled
Just fix it.
Yeah,
Something must
or
work.
settles, what do you have on you? I don't know.
Belt.
A belt to try and fix this.
It could be a shoelace.
Or a shoelace.
Yeah.
Before we get a technician to come in to help fix the problem. Now, in this, paint for us a picture or a scenario where you find the nurses improvising, and how do they improvise? And then then the shortages. What does this then do in terms of creating survival for newborns? Does this then become very risky for the survival of these newborns? Or what happens? First, improvising. How do they go about this? If you have to take care of 25 babies, and you said it's taking care of 25 mothers. So you have 50 patients and it's one nurse.
So I think the situation is that first, it's important to paint a picture that in a lot of these places we've come a long way, and there are a lot of investments being made in terms of ensuring we have adequate resources to look after newborn babies. It's not perfect, but it's improved. So you will find, we have a lot of some of the equipment that we need. The challenge is, even if you had all the equipment that you needed, and there's only there's only so many equipment that you can use at any single time. Mm-hmm. So it's not an issue of sometimes the resources. It's sometimes it's and people forget that because governments invest in buying all these excellent equipment and put them there, but they don't get used because if I'm just me, I will choose to just use one equipment which I can do a very good job with. So having said that, the next thing to reflect about is, if I walk into a shift and there are 25 babies, the priority goes to the critically ill babies. Okay. So if you're relatively stable, we will work with the mom to say, hey, if you see any of these three things, give me a shout. But in the meantime, you focus on the very sick babies who, it's a matter of life and death for them. So that's where nurses focus. The prioritization is really on the critical tasks. And the more stable babies then get, the long end of the stick. But because a baby is supposed to have, every 4-hour monitoring, then they get that monitoring maybe once or twice a day. In terms of medication, then we in a lot of the county hospitals, the benefit that they have is a lot of them are used as training grounds for medical schools and nursing training schools. So you'll often have some students in that environment. So you get those students to help you provide that care. But the unfortunate bit is that care is provided unsupervised, which introduces a patient safety concern, because this is someone in school.
Unsupervised by whom?
Ideally, you're supposed to be supervised by the nurse.
Okay.
As a student, but there is only one me in the critical in that critical room within the newborn unit.
Okay.
So if I let you go as a student in where the stable babies are, then who is looking at what you do?
Are these like ward assistants?
Not ward assistants, nurse students.
Nurse students.
You see, like before you graduate with a diploma or degree in nursing, you will have some period of clinical practice. In a clinical setting. But you've just come straight from classwork, and here we
You're
go.
learning on the job, basically.
Technically, yes. And we set a very bad example, because we are telling students it's okay to work with 25 patients and not do monitoring as it's supposed to be.
Like the case I've just mentioned, this was an intern, and she was subjected to working in very extreme conditions, 40 hours standing, walking around, and it was too depressing. Which then leads me to these other questions. The mental well-being of staff in this kind of environment where you're so strained, you're working many hours, you have to then pay attention to all these patients, and then you have to then prioritize, like you're saying, okay, let me deal with the 10 or 15 critical cases, then these other ones to even make those kind of decisions as you're moving. How has it been then for nurses?
So I think we put them at a very tough situation, if you ask me, and it's a very tough moral, ethical dilemma on who should I look after, who should get the most care from me. How do I choose? How do you prioritize that? And every time when you go home, sometimes there are bad shifts when you lose 2 or 3 or 4 babies, and there are times that you sit down and reflect that maybe that baby, if only I had an extra 5 minutes,
I would have saved their life.
But someone called you, there was a baby needing resuscitation, you went to resuscitate that baby, another one choked on something. So it's really tough, and because of the workforce shortages, so there's the component of working in this high risk, high mortality setting. You've made a bond with the mom, taken care of a baby over 3 weeks. You've made a bond with that baby, a bond with the mom, and then you lose that baby. It gets onto you. But there is also the aspect of, because there isn't enough of you, you don't get enough rest also. So you coming on duty every day because there isn't enough of you to go around and allow for leave.
Yet, Dr. as we talk about the numbers that for healthcare workers, for neonates, or just in the healthcare system, we also look at the numbers and droves of nurses leaving this country because of lack of opportunity. And one asks the question, as we talk about provision of healthcare in the country now, the government is pushing universal healthcare, and one of the important components would be healthcare workers to ensure that the mortality rates that we record continues to go down. But that does not seem to be the situation. Many nurses, especially nurses, are leaving this country. But that is one component. As we talk about the newborn units again, we look at what we need in these newborn units. So we need the warmers, we need the incubators, we need the CPAP machines. All these things have to be managed again by the very nurses who are leaving. So where is the balance in ensuring that we, as we say, the situation is improving, it is improving at a commensurate rate, at a commensurate pace, so that we handle the situation better?
So the unfortunate, well, I don't know to call it unfortunate or fortunate. There's a paradoxical shortage of nurses in Kenya. If today you advertise for nursing positions in the Ministry of Health, they are usually very long queues that go up to Uhuru Park. Mm-hmm. So it tells you we don't have a shortage of trained nurses, which is what most other African countries are struggling with. They have money, they have space, but they don't have people to recruit. Mm-hmm. So we are at a different situation. Why I say it's fortunate is because if we had the money, then we can employ. It's unfortunate that we have these nurses and we don't provide opportunities for them to provide care to Kenyan citizens who subsidize their education. In terms of why we have a shortage, and it's really not a planning problem. I think sometimes we preach to the converted. Gathara, we studied in a room full of people from the Ministry of Health and Ministry of Health stakeholders, but he never speaks to the Ministry of Finance. And the Ministry of Health never communicates the problem very well to the Ministry of Finance, because it's a financing problem. Today, counties have a budget ceiling for health workforce. How many people, what proportion of your budget can be workforce? So all those things are really, if you look at them, they just go back to financing.
Okay, so let's look at what happens when these things as prerequisites then are not done. If in can I call it a neonatal unit?
Yes.
All right. If in a neonatal unit, there's one nurse, and give or take, basic neonatal unit has how many babies, beds? How many? On average?
Let's say one nurse to 20, 25.
No, I mean the actual babies.
On the actual babies.
Yeah.
Some places can go up to 90 babies,
okay.
100 babies.
100 babies in one unit,
yes.
in one facility.
Yes.
All right. And there would usually be only one unit in a facility.
Yes.
Okay. Unless you're looking at special care, HDU, ICU babies, yes. Right? So how many nurses then are assigned to a number of babies? One nurse to how many babies?
So I will start with what is the official number.
What should it be?
World Health Organization global recommendation is 1 to 2, 1 to 4. We recognize that moving from 1 to 25 to 1 to 2, 1 to 4 is a huge toll. So a lot of the work now we're doing is to say what would be a reasonable number. What would the roadmap will look like. And I think that's the honest conversation we need to have with people, because all the time we tell people, this is the global recommendation, this is what you should adhere to, but we don't give them room. We know we have a fiscal space problem. I think we need to engage policymakers, decision makers, people who sit at the budget making table to recognize that over the next 5 years, we can move from 1 to 25 to 1 to 15. And what does that do? That will improve the care that is delivered by X, and it save X number of babies.
Okay, so the number is 1 to 25 officially.
The number that in our units right now
is what it is. What is the recommended?
1 to 4.
So there should be one
nurse to 4 babies.
So there should be one nurse to 4 babies.
Max, yes.
So let's say that there's one nurse to 4 babies. So let's do this practically, because usually we talk about things as though it's pie in the sky, and we don't really connect with the issue, right? So 1 nurse to 4 babies means that for everything that needs to happen with this child while they are in hospital, whether it's the administering of drugs, whether it's the checking of vitals, whether it's keeping their charts changing, bathing, all of that, 1 nurse can handle this for 4 babies over the course of their shift, the 8-hour shift. Right? 10-hour, 12-hour shift.
That's on the extreme. Ideally, it should be 1 to 2 because newborn units are more like ICU units.
Okay.
But we do appreciate that even with 1 to 4, you'll be able to provide a lot of that care that you mentioned.
Okay. Ideally, it should be 1 to 2. It's recommended it be 1 to 4, but the reality in Kenya today is that it's 1 to 25.
Yes.
All right. That obviously is a more than heavy burden on the caregiver, the nurse, and, because the doctor is not there for as long as the nurse is. That's for sure. What do they do during this 10 to 12-hour shift for these children, for these babies? What do they do?
So I will flip that question and tell you that when you have 1 to 20, 1 to 25, it means a nurse only has 30 minutes per baby over a 12-hour shift. The question is, how much can you do? And that assumes no breaks. Your business is just looking after babies. So the question then we can ask is, what can you do in 30 minutes?
Okay, no, I'm asking because what are you because what are you supposed to be doing for these babies in this neonatal unit?
So what ends up happening is what I said. Nurses prioritize the care. They prioritize the most critical things. A baby requires a machine that needs to help them breathe. Then you set up on that machine and monitor that very critically ill baby. You make sure they are having fluids being given, the medication is being given. Other tasks are shared with the mom. Sometimes well supported, sometimes moms are not supported to provide that care. So in the work that we did, it actually illustrated nurses only achieve 30% of the care that they need to provide. And the other 30% is complemented by mothers. So 30% is missed. So during that period, when you have only that minutes per baby, you prioritize the very sick ones. And even for those, then you don't even get to do everything that you're supposed to do.
Okay. So there is the possibility. And usually, unfortunately, if you don't look at what could happen in the worst case scenario, then you're likely not going to be prepared to take care of the situation before it gets bad or worse.
Yeah.
So what could happen? What could happen? Could a nurse you could naturally get tired, you're fatigued, you would make mistakes in a neonatal unit. Can you? Yeah. No.
It does happen.
Sure. But what could we be looking at that could happen? So because I know you know where I'm going with this. Because if we don't do what is required, what could essentially happen to these 25 babies, even one of them, when somebody is compromised in terms of their health, in terms of their fatigue and all of this?
The honest truth is people die.
Babies die.
Babies die in those units. And if you talk to nurses, they will tell you it's a tough situation when, a baby dies on your watch, and it's not your fault. It's because, there's only so much you could do, and it's very sad. And until we get people to appreciate that someone pays the price for not having enough staffing in these units, and a lot of the times it could be those babies.
It's a very difficult situation to be in because you're dealing with the question of numbers. To save a life, just 1 second, if you miss just 1 second, is the difference between life and death. And I can only imagine the stories that come from those units. And if then somebody can talk to nurses, what they watch, because what we then end up getting from our side is the numbers. Oh, we've lost this number of babies within this month, or a family is told that, unfortunately, your newborn has died. And it's very difficult then to follow up, okay, what are the reasons? And what you're saying is then the nurse goes home knowing that if I only had an extra minute or 5 minutes,
or an extra other nurse, if there was only one person in that room, they would have picked the problem, they would have solved it.
We're talking about even if you look at the WHO recommended numbers, it's still 1 nurse to 2. And here's a situation where if both are in critical position where they both need to be resuscitated, who do you pick? Even using the WHO numbers, it's still difficult. But here we're talking about, even with that, it is 1 to 25. I remember when Hamza, my son, was being born. I remember walking in there and he was in a warmer. And at that point, anything could have happened if he had not gotten any help. And I remember he was on the warmer alone as the nurses were dealing with other babies. And when I look back at that point, perhaps the staffing was not up to par. And anything could have happened. And these are realities that we deal with on a daily basis. And one would hope that in a country that is pushing for universal health coverage, these are things that would be given priority, yet seems as though it's not. So from where you sit, these conversations are things that happen on a daily basis. These are conversations that especially nurses in this area are speaking to government on a daily basis. Any response?
The thing is, we not communicated the problem very well in the past. We've always said there are health workforce shortages, there are nurse workforce shortages, but we've never been able to illustrate or, put the foot down and say, this is what it means when you don't have enough nurses. It means a nurse has 30 minutes per baby. It means care is not delivered. It means people die in those situations. And we need to start communicating to people at the budget making table, policymakers, that an investment in workforce is not an expense, because that's what people sees it. Because when I employ you, what do I get in return? I pay you every month, but they don't see the return, because we've never been able to present the information that way, that for every nurse employed, for every staffing ratio improved, then you save this number of lives. Then you reduce this number of long-term complications that the baby will leave the newborn unit with. So as an economist, I will see that there is value in me employing a person rather than having a baby who will have long-term complications that the government will have to take care of. It's a cost. They will not have anything to bring into to the economy.
Okay.
So we need to repackage what we call workforce shortages.
So we, of course, this is kind of like an appendage to a conversation that we had last week, and just looking at, because in the neonatal units you depend on nurses to then be able to do. The doctor will come in to offer and to work their expertise. They will take care. If there's a surgery that needs to be done, they will do that, and they will advise. The one who stays with these babies, and we're talking about babies now. This is the beginning of life, and that's why we're focusing on that. But the one who takes care of them is the nurse. They're there. That's 24-hour watch until they're able to be moved somewhere else. What a nurse is paid, how many are hired, how many of them are on shift, are crucial elements of this conversation. That there are fewer nurses hired is not because there is a lack or that there's a shortage of qualified nurses in Kenya. We know this because there are nurses who are leaving by the droves to go to other countries to work. I know people today who are studying nursing. After having finished another degree, they are studying nursing so that they can go to the UK in the next 2 years and begin work. It is true, and I'm sure you know this as well, to leave the country. So Kenya doesn't have a shortage of nurses. Doesn't have a shortage.
No.
What Kenya has is a lack of desire to put these people in paid positions to take care of its sick. I don't even think it's a resource issue. And we can get political here, but I don't believe it's a resource issue. If we wanted to find the money, we have found 300 billion shillings this morning to pay. Who are those people? We found 300 billion shillings. And if a bill goes through, we will find 300 billion shillings to people who no longer work for Kenya, but are in retirement. Surely we can find some 300 billion shilling to pay people to work for these children who are just starting their lives? Am I going off track?
No, we should be able to find the resources, and I believe it's a prioritization issue. And the sad thing is, so as part of the work that we did, we recognized the problem and said, we'll stop admiring the problem. Let's put in an additional number of nurses in these units and demonstrate that you get, improved nursing care. And the unfortunate thing that happened is that once we put in the additional nurses to the newborn units, what ended up happening is, because all these other units are really struggling, the hospitals moved their own staff to other units and left the nurses we'd employed. So, eventually, so for example, if we wanted to move the total number of nurses in a newborn unit from 12 to 15, for instance, so we put an additional 3 nurses. But because they can't move the nurses we put in, then they pull out some of theirs. So instead of having 15 now, we end up with 12 or 13. So we have really not improved the nursing staffing as we had anticipated. And sometimes you can understand, you can reason with management, and I really figure out that they really didn't have a choice. There was a unit that was struggling, almost being closed down because they didn't have nurses, so they needed, and one unit was looking like they're having a good time, so you pick one of them. So it's not only a newborn issue problem of staffing, it cuts across all departments. And I think the newborn unit just presents an opportunity of highlighting the problem. We say how you treat the most vulnerable populations in the country or in the health sector is a good lens of how good your health system is. The second bit I would like to highlight that maybe often forgotten is nurses never have any support or help in the newborn units.
How so?
A lot of the newborn units is just nurses. So if you need to go to the stores, you as a nurse have to go to the stores. If you need to go and collect medicine from pharmacy, it's the nurse's responsibility. If a baby is discharged and the file needs to be taken for billing, so that the baby is the hospitalization is billed, and so the baby can go home, it's the nurse. You can't send the mom with a patient file. A nurse has to find time to take that file to billing. A lot of the times there is the benefit of students, but if there are no students, it becomes a nurse's role. So,
what about ward assistants?
So ward assistants are not a standard cadre in a lot of public hospitals. So in the work that we did, we said, from our experiences, we had realized that also nurses are also spending time on non-technical things, going to the stores, to the pharmacy for billing, to the lab, things that they can be supported. A lot of those things are non-technical, non-patient facing. So we felt that there is opportunity, because they do exist in the private sector, is there is opportunity to create a mechanism to provide support staff and help people appreciate the need, the support that nurses need. Even just someone to organize or look for some records at the nurses.
Is it not a question of communication technology? Because if a nurse then is in this unit and they need a file or record of the mother, or they need lab results, why do you need to physically go to the lab to get the records, then come back to the Why not use an internal system that makes it easier? You just press a button or just make a call, and I don't know.
And is this a public hospital?
No, that's why
it's not digitized.
I know, and that's why I'm asking. Why then don't we move this conversation to say, hey, look, we need to also improve on our communication and introduce technology. If you ask today, if you ask some of these young fellows, create an AI system or create a system that will assist. There are many bright, extremely bright students out there who can create a very seamless system where you don't need to do it, just like the way it works in the private. If you need to find out from the pharmacy, is the medication available? Is it out? It's just a matter of getting into the system,
Hang on. So I think the technology bit can solve a small part of that problem. But someone needs to take the medication from pharmacy to the ward. Who does that? Is it the pharmacist? Should the pharmacist close the window and go take the medication to the ward, or the nurse should leave the unit and go to the pharmacy? And these are public sector hospitals where even that extra workforce doesn't exist. So just creating people who can, for lack of a better word, clerks or messengers in those environments with some level of training on infection prevention, so that they're not becoming they are not producing problems instead of becoming solutions. It makes a very huge difference.
And are these not conversations that they are aware of? We're sitting here, actually we're discussing solutions.
Yeah.
We're actually literally discussing solutions. In the boardrooms, they say vitu kwa ground in different, but when turudi kwa ground, do these conversations happen within these institutions? Like, hey, look, either we need to, we sincerely need to get an assistant, sort of what you call an office messenger, but somebody who has at least some medical background, and like you're saying, a bit of training, and it can even be training on the job. This person's responsibility, or these people's responsibility, will be you uko kwa pharmacy. If this comes in from the pharmacy and he needs to go to that ward, your job is to ingia lift or take the stairs, take it there, then come back. Do these conversations happen?
I think. I don't know. To be honest, the way I see it is, it exists in two ways. I think sometimes in health sector there is this notion of if it's not broken, don't fix it. Yes. So if the status quo works, if people can work in their very stretched environments, and people still come and go home and a few die, don't touch it. But we need to be honest with ourselves and say, it's not working, it's broken, someone is paying the price. And the second perspective or concept of nurses are not very empowered. Healthcare is very hierarchical. The people who sit at the table and make decisions, a lot of times you will not find nurses on those tables. So nobody articulates those issues in a way that can bring the issue home of what it means that if I'm the only one on duty and I need something from pharmacy, there will be a period of time the newborn unit will be unmanned.
We had a nurse here last week, and we just asked the question, if nurses were removed from the hospitals, how will a hospital move? And we agreed the hospitals would not exist. There would be no reason of having a hospital without nurses. Goes to speak on the importance of having nurses in our hospitals. And with that in mind comes the question of our priorities, especially when it comes to matters healthcare. You say decision making, it's hierarchical. Yeah, that one. Decisions are made with people, and nurses are not involved in there. So are we having our priorities right when it comes to matters healthcare? Are we involving the right people to help us move these forward? Are we employing the best tactics and the best knowledge in the current dispensation, the current world, to deal with these challenges? Case in point, technology, bringing in people who will help the nurses in getting medication, in clearing the billing systems. Are we doing all these things, or are we just seated saying, at the end of the day, mambo inasonga?
To some degree, I think it's the latter. As long as patients can come in, some go home, some, we're happy that we can get a little bit money from SHA as reimbursement.
If that.
if ever gets to you. So there is that we are not willing to be disruptive and have honest conversations on what needs to be done. And I will give another example about we have had recent funding cuts from USAID, from Global Fund. A lot of the people, the health workforce personnel who are supported by those programs, were let go. Does it mean they didn't have jobs? Does it mean they were just hanging around hospitals? No. They had critical roles that they were playing. So I think we're not very deliberate about how we plan, and and prioritize what really counts. We have hospitals that have been built that cannot be opened and launched because we don't have health workers. Yeah, so
I want to go back to this issue because I think we talk about it, and sometimes we there's some humor that we apply to it, but it's actually quite serious. That we are talking about a neonatal unit whereby there is one nurse who is on duty, and maybe on that day there are babies who are going to be discharged, or there's medication that needs to be given to these children, public hospital or not. And we don't even have something as basic as a messenger system, whereby somebody who doesn't need to have a medical degree to take medication that's already been packaged, put on a tray or in a carrier bag, to leave pharmacy and come to the ward. They're not asking you to open it. They're not asking you to administer it. They're not asking you to do. You don't even have to read the labeling. All you have to do is take it from there to here and bring it to the ward. That's it. But we are saying that even that we can't do. It has even been suggested.
It doesn't exist in the public service.
But surely somebody can say,
Exactly,
because these are solutions that surely somebody can say, like, I'm here sitting in the studio, I need something that needs to be done in the city. There's somebody in the city who can run for 100 shillings and we have it done, right? And here we're talking about people's lives. That in a sensitive unit where there are babies who just began their life that need 24/7 watching, we are saying that remove the one person who is taking care of them to go. And we also have been to pharmacy in a public hospital waiting for medication before you come back. And we're saying that we can't even have a runner system. Even that we cannot do. Because
it doesn't exist. Well, when we tried to do this work, we asked, where would we put them how should we pay them?
Piped water didn't exist. And we used to just have open defecation. In some cases, we still do. But somebody said, you know what? This would be easier if we had this water moving in this direction and we can, patch it to people's homes. That doesn't. But in this day and age, we're saying that you have to have a filed system and that we need to live delicate lives. So is that what happens? I'm sorry, I met with such chagrin. But is that what happens? That these babies essentially are left unattended and somebody has to go downstairs, upstairs, wait for 45 minutes. Babies are unattended? Or am I just saying something that doesn't exist?
No, it's a reality. Because as a nurse, I have to make the decision of whether these are very critically ill babies, whatever interventions they need, it's the drugs that are in pharmacy. I don't have them with me. And it does happen that, there will be those instances where someone was supposed to bring in all the drugs that you need in the unit during the day. A special case shows up. You don't have the treatment they need. It's in the pharmacy. There's only one you have to decide, should I go for this drug? Should I stay in the unit?
It's a situation where if we live in a society or in a country that has no regard for life, what about newborns? What about taking care of the sick in hospitals?
That's what Dr. Harry said. It's okay.
If
a few will die, it's okay.
If you have no regard of even the type of medication that somebody is taking, whether you're taking fake medicine, and we've seen this, or expired medicine. We've had situations or instances and stories where expired medicine is still being given
in government
hospitals to patients, or donations. Medicine, it's still so, and it's a donation. Right from COVID, I covered the COVID story, and I remember things that were given for free, PPEs, everything that was given for free was actually being sold to the public. So if we're in a state where there is no regard to human life, that you're not thinking, what if this person, you're not thinking the survival of this person who is sick. And if you draw back a bit, there is no regard to even provide medical care to even newborns. Then these nurses have nothing else to do, because the people who make these decisions then, like Undi is saying, and that's the question I was asking earlier, we're having these conversations in this studio and basically we're having solutions, but in these boardrooms, do they ever sit back and ask nurses? Actually, they can't, because we were looking at the headlines today. Actually, we were looking at the headlines today. They're asking for medical cover for overseas. So these people don't go to the public hospitals. But if there was a law, or we had someone who will then say, from today, there is no single politician from CS level to whoever who's going to go overseas or go to any private hospital. You have all to go to public hospitals. Then they take their babies there. Well, most of them don't deliver their babies there in any case.
Why should they?
They're juniors anyway. So if we had a situation where they will be forced, these politicians will be forced to take their wives, to take
themselves
and sisters and themselves, to then go where you'll find a nurse taking care of 25 newborns, then things will change in this country. Yeah. But for as long as they've never, as far as they go, we were told the other day, Kiambu alone, the governor was shocked walking into a hospital and seeing there are no people.
There are no people.
Yet there's a strike that has been going on for 3 months. But the governor seems not to be aware where are people in his own county.
You know,
that tells you, does it mean the governor doesn't get sick? Of course he gets sick. Yeah. But where does he go to hospital?
You know, as we just talk, goes to show a political class pretty much that looks at people as a tool, as capital. So neonates, why care? What do I get to benefit from them? I will need to go to some guys who I'm sure will give me their votes. I'm sorry, but that's how I look at it. Someone thinks of neonates and, no, until they're 18, then maybe I will start having that discussion when I can get something from them. Yeah. It is sad that you're having that discussion in this studio like we are.
My last question will be this. The shortage of nurses, the shortage of all these things. Let's talk about infrastructure in these neonatal units. How is the, from your research, how is the infrastructure like? Because we've also had situations where equipment is bought, but that equipment cannot fit into a room, or the room needs to be ventilated in a certain way, padded in a certain way for it to either function, or it requires a standby generator, because you can't definitely just depend on
the grid system.
So in this situation where the equipment has been bought, but there is no place where it can fit, or there are no professionals to manage. From your research, how is the infrastructure within these units?
So the thing about newborn care is it's only in the last maybe 1-2 decades that it's really gained a lot of traction. And a lot of those units were afterthoughts. They were repurposed parts of a maternity unit. So they knocked down, a sluice room or, a corner somewhere and realized we have sick babies, we need to look after them somewhere. So they really, in some of the places, they are very small rooms. It's pretty much a room like this one with babies cots around the wall.
You say like 4 babies will be bundled into one cot?
Because of space. Yeah.
What so is this in your mind? Is this happening in your mind, or this is a reality?
This reality. You walk into, any typical county hospital. There are very few county hospitals, I can tell you for sure, that don't have babies who share cots. Very, very few. Okay. And we've been in those spaces and we've seen it.
Maybe one is critical, one is not, but they're all in the same.
And if they are not sharing cots, then they are back to back, like the way we
sausage,
like orbit. Cots are like this. They are the cots are even making contact, which means then you're not even solving the infection prevention problem that you're trying to solve. And there are units where they've had the benefit of having equipment donated to them, but they can only fit 2 of those equipments in that room. Okay. Because remember that also these equipments are dependent on electricity. The wiring of that room was not designed for warmers, for incubators, for phototherapy equipment. The moment you plug all those onto the wall, onto an extension cable, you trip power.
Okay. Doc, you know what? We need to continue this conversation, but one of the reasons why it is necessary for us to talk about it is that then we live in an alternate reality to imagine that such things are not taking place when we want to spend our time focusing on conversations that don't matter. When we look at the real scheme of things, we want to thank you for being here this morning. In as much as a lot of the reality that you've brought out to us today is then necessary for action, and so that's why we keep talking about it. Necessary for us to do. but then our time runs out for us on sometimes. But thank you for coming this morning, and this is definitely one conversation that we will not stop having until the little gains are made one by one. Professor David Gathara is from Kemri. Welcome. He's joined us this morning. Thank you so much for doing that. We look forward to more in the future.
This is the Situation Room, the only way to start your day.